Hello students, in this video I'm going to take this topic which is very important, that is glucose transport. Why this topic is very important? Because glucose is polar. It is a polar compound, it is polyhydroxy, right? But cell membrane is lipid bilayer membrane. So how this polar compound glucose will cross the lipid membrane and reaches the cells, because it is the main molecule, which is the main raw material which is required for the cells, right? So because there's a problem of polarity and non-polarity here, that's why this is a very special topic. And we have to see how body has solved this problem. What are the transporters required? Because there should be a channel in the membrane. In the membrane, a channel should be there via which glucose is going. As such, glucose cannot go via the lipid membrane. There is a channel in the membrane. And these channels are of two types. One is facilitative transport, also known as GLUTs. GLUTs stand for glucose transporters. GLU stands for glucose. T stands for transporter. And this is sodium independent method of transport. Sodium is not required here. But the other one, that is second, active transport, which is sodium dependent glucose transport, that is also known as sodium glucose symport. The short form used here is SGLT. S is sodium, GL glucose, T is transporter. So the short form here is GLUTs. The short form here is SGLT, right? Now this active transport is against the concentration gradient. That is because energy is used, so it is against the concentration gradient, and it is unidirectional. See, because we are using energy to take glucose somewhere, so obviously we are taking glucose in one direction only, that is inside the cell where it is having a use, right? So only in one direction, it is unidirectional. And this active transport is present at very few places in the body, that is only in intestine and kidneys. See, why in intestine? Because in intestine, we do not throw any glucose normally in our stools. We have to absorb all of it even against the concentration gradient. That's why active is present in intestine. And in kidneys, we do not throw any glucose normally in urine. So we have to reabsorb all of it even against the concentration gradient. That's why active has to be present in kidneys. But on the other hand, let's see this facilitative transport. This is down the concentration gradient. Like passive transport, it is down the concentration gradient, and it is bidirectional. That is, glucose can enter the cell via GLUT. It can leave the cell also via GLUT. But if this is happening, then it is of no use. That is, glucose entering also, leaving also, no. What is happening in the body is that when glucose will enter a cell, quickly it is converted to glucose 6-phosphate. Because if it is glucose, then it can escape the cell via GLUT. So if it is glucose 6-phosphate, then it cannot escape the cell via GLUT. So the cell is doing this first step of phosphorylation for the entrapment, right? So can I say phosphorylation of glucose is done for the entrapment of glucose inside the cell, right? Now let's do the detail of both these transports one by one. First, I'm going to take active transport. Active transport is also known as sodium glucose symport. Symport means same direction. Now let's say this is a cell. This is a cell, and let's say this is symport. That is, both sodium and glucose are entering the cell, both entering in same direction. So here, how many ATPs are used? If I ask you, how many ATPs are used when glucose is entering via active transport? Answer is 0 ATPs. But tell me, if 0, then why do we call it active transport? See here, the reason is, whenever sodium is coming inside the cell, then sodium has to be thrown out of the cell also, so that the same molecule of sodium will be used for taking another glucose inside. Now, how do we throw sodium out of the cell? This is with the help of sodium-potassium ATPase pump, which is used here. So energy is used by this pump actually. Energy is not used when glucose is coming inside, right? See, this is a way of glucose transport, active transport, but energy is not used when glucose is entering. Energy is used when sodium-potassium ATPase pump is used. That's why when in books you read this topic, they do not write it active transport. They write secondary active transport, also known as indirect active transport, because energy is used indirectly. Now this active transport, SGLT short form, it is of two types, SGLT type 1 and type 2. SGLT1 is for the transport of both glucose and galactose, and it is present in both intestine and kidneys. But SGLT2 is only for the transport of glucose and present only in kidneys. Now let's do the detail of facilitative transport, that is GLUTs. We have to do this table of GLUTs, glucose transporters, that which GLUT is present in which location and what is its function. We will not cram this table. We will go with the concept, and I will go while I take a formula here. That is, the formula is affinity is inversely proportional to substrate concentration, and GLUT1 and 3. GLUT1 and 3 I'm going to take first. GLUT1 has high affinity. Even GLUT3 also has high affinity. That's why I'm taking them together. They have similar properties. GLUT1 and 3, they have high affinity. So apply the formula. High affinity means low substrate is required for them. What is the substrate for GLUTs? Substrate is glucose. So for GLUT1 and 3, less glucose is required. So less glucose, low glucose is present during fed state or fasting state? Obviously fasting state, right? So that means GLUT1 and 3 will open during fasting. These are channels for glucose transport. They will open during fasting. Now think yourself that if they open during fasting, then they are present on which cell of the body? They are present on those cells of body which always needs glucose. Be it fasting or fed state, these cells always require glucose. That is brain, RBC. If the baby is there, then placenta. Also in kidneys for reabsorption, right? So see the location. GLUT1 is present in brain, placenta, kidneys, also in RBCs. But GLUT3, brain, placenta, kidneys. So brain, placenta, kidney is same for both. But you have to learn that in RBC, we only have GLUT1 and not GLUT3, right? And see the function. Function is same for both GLUT1 and 3. That is glucose uptake during fasting, right? So we're done with this much. Now let's come to GLUT2. Now GLUT2 has low affinity. Low affinity means more substrate required, more glucose required. More glucose is present during fed state. That means GLUT2 is active during fed state, right? Now GLUT2 is, when it is active during fed state, then what is the requirement? It is present on which cell of the body? See, when we are eating food, then in intestine, we have to absorb glucose. So a channel should be opened in intestine at this point of time. Now when glucose is entering the blood, then see, right now in fed state we are eating food, but we are not eating all the time. In between two meals, liver glycogen will be used up for maintaining blood glucose levels. So right now when we have excess glucose in fed state, we can send it to liver for storage for future purpose, right? So a channel on liver should open. Plus one more function required here is that right now we are eating food, so hyperglycemia is going to occur. So insulin should be coming to decrease this blood glucose. So that means some channel on pancreas should open, because this glucose will be entering pancreas and giving this signal to pancreas that glucose is present in the blood. So pancreas will do its work of release of insulin, right? Now, therefore, GLUT2 is present in liver for glycogen formation, present in pancreas for insulin secretion, present in intestine for absorption, right? So now when insulin is released, then insulin will come in blood and will activate the next GLUT. In our sequence, as we are done with number 3. So insulin activates GLUT4. Next is GLUT4. So insulin activates GLUT4, and now GLUT4 has to do the hypoglycemic action of insulin. So GLUT4 should be present where? Let's see. Let's say this is blood vessel. This is blood vessel. In fed state in blood vessel, we have lots of glucose molecules here. So here we want to achieve hypoglycemic action. So this glucose can be thrown into the peripheral tissue of the body so that in blood we achieve hypoglycemia. So which are the peripheral tissue of the body? GLUT4 should be present on those tissues, that is skeletal muscle and cardiac muscles and adipose tissue, right? When glucose will enter into muscle, then it will be converted to glycogen, and when glucose will enter into adipose tissue, it will be converted to fats, right? So the function of GLUT4 is insulin stimulated glucose uptake after meals, right? So these four, from GLUT1 to GLUT4, we have done in a sequence, right? So do revise it in the same manner. This is a conceptual way of reading the things, understanding the things. Next is GLUT5, which is especially for fructose transport. That's why it is present in small intestine and testis, especially in the sperms. Next is GLUT6. GLUT6 is present in WBC and spleen. The function is not known, so it is not very important. Next, GLUT7 is present in liver endoplasmic reticulum because the function is glucose transport in the endoplasmic reticulum. So you can take these notes in a flowchart form like this. GLUT1 and 3, they have high affinity. High affinity means low substrate concentration or low glucose is required for them, and low glucose is present during fasting. So we can say GLUT1 and 3 are active during fasting. And similarly, for GLUT2 also we can write like this. GLUT2 has low affinity. Low affinity means more substrate or more glucose is required for GLUT2, which is present during fed state. So we can say GLUT2 is active during fed state. Now let's see the sequence of events occurring in fed state. In fed state, when glucose enters blood, then the first GLUT which gets open is GLUT2 is opened. When GLUT2 opens, then glucose will enter pancreas. You know, liver and intestine also, but here I'm more concerned with pancreas. So let's continue. Glucose enter pancreas, so hormone insulin will be released. Insulin will it will make GLUT4 active, and GLUT4 will cause the hypoglycemic action of insulin, right? So this is the sequence of events. So from the sequence, let's solve few questions. Now tell me, is GLUT1 and 3 dependent on insulin? GLUT1 and 3 dependent on insulin? No, GLUT1 and 3 are in fasting. Insulin is always in fed state, so there's no relation, right? Now tell me, is GLUT2 dependent on insulin? See the sequence. GLUT2 comes before insulin, so GLUT2 is also not dependent on insulin, right? Only and only GLUT4 is dependent on insulin. Now, what is the problem in a diabetic patient? That insulin, there is relative or absolute deficiency of insulin. When insulin is not there, then GLUT4 is not activated, then hypoglycemic action is not achieved. That is, all the glucose stays in the blood vessel, not entering the cells. So cells think that we are in fasting. In a diabetic patient, the cells will think that we are in fasting, we're not getting glucose. So I can say that diabetic situation is same like fasting situation. Whatever concepts I will be telling you about fasting situation, apply all those concepts in solving the questions on diabetes. This way it will be very easy to solve the questions on diabetes. Now, as clinicians, sometimes we will tell our diabetic patients to do little bit exercise after each meal, brisk walking after each meal, and this will help reduce your blood glucose levels. Tell me, when insulin is not there in a diabetic patient, then how can it help reduce blood glucose levels? There's a reason here, because exercise can directly activate GLUT4, and this action of exercise-induced activation of GLUT4 does not require insulin. This requires an enzyme, that is 5-AMP activated kinase. 5-AMP activated kinase. This can be a question. So now you have done both kind of transports are present in intestine also, in kidneys also. That is, here facilitated transport is also present, active transport is also present, right? So let's see how this is possible. See, this is intestinal cell. This is intestinal cell. This is apical side of the membrane. Apical side of the membrane, which is towards the luminal side. This is basolateral membrane, which is towards the interstitial fluid and blood. Right? Where is GLUT present? Where is SGLT present? See here. Here on the apical side, SGLT1 is present in intestine. Okay. And here on the basolateral membrane, GLUT2 is present, which is active during fed state for absorption of glucose, right? Now, in kidneys also, both kind of transports are present. So see this diagram. This is the renal cell, and here this is lumen side. This is luminal side, and this is interstitial fluid or blood side. Here this SGLT is present, which can be SGLT1 and 2. 1 and 2 both are present in kidney. And on the basolateral side, GLUT2 is present. GLUT2 is also present in kidneys, right? So GLUT2 is present on basolateral side, and this sodium potassium ATPase pump is also present on the basolateral side always, right? So that means in kidneys we have many glucose transporters present. So let's see, in kidneys GLUT1 is also present, GLUT3 is also present, and GLUT2 is also present. GLUT1 and 3, they are high affinity transporters. They have high affinity for glucose. And GLUT2 is a low affinity transporter, right? So this is the facilitative transport present in kidneys. And in kidneys, SGLT, the active transport, SGLT1 and SGLT2 both are present, right? Like GLUT1 and 1, 2 and 3 are also present. SGLT1 and 2 are also present. SGLT1 is a high affinity transporter. Like I told you, GLUT1 and 3 are high affinity transporters. SGLT1 is high affinity transporter, and it has low capacity. Low capacity means it is responsible for the reabsorption of only 10% of the glucose. Okay, SGLT1 has high affinity but low capacity, that it is only responsible for the reabsorption of just 10% of the glucose. And SGLT2 is low affinity transporter, but it has high capacity. It has high capacity, that is 90% of the glucose is reabsorbed using this SGLT2. Okay, so we can say that SGLT2 is the main active transporter in kidneys, right? Now let's see some of the mutations. If there is mutation in SGLT1, I told you SGLT1 is for the transport of glucose and galactose present in both intestine and kidneys. So SGLT1 mutation will lead to glucose galactose malabsorption. Okay, then if there is mutation in SGLT2 is only for glucose, present only in kidneys. So mutation of SGLT2 leads to familial renal glycosuria or glucoseuria. Okay, kidneys are affected. Okay, this is glucose coming in urine, so called familial renal glycosuria or familial renal glucoseuria. Okay, then one more mutation you have to learn, that is mutation in GLUT2. Mutation in GLUT2 leads to Fanconi-Bickel syndrome. These are the name of the scientist, Fanconi-Bickel syndrome. And this Fanconi-Bickel syndrome is also known as glycogen storage disease type 11, also called glycogen storage disease type 11. As you know that GLUT2 is present in intestine, liver, pancreas, also I told you kidneys. Okay, so here there is hepatorenal glycogen accumulation. hepatorenal glycogen accumulation. These patients have growth retardation, polyuria, polydipsia. These patients have fasting hypoglycemia, but postprandial hyperglycemia resembling diabetes. So it's like mutation in GLUT2 can lead to a situation like diabetes. So these patients have postprandial hyperglycemia. Okay, so we have done these 3 mutations which you have to learn. Okay, and this is it with this topic of glucose transport. Thanks for watching. Best wishes.